Ma'am, please start. We are now online.
Namaskar and good evening, everyone. I welcome you all for the webinar on newer advances in oncology, the second day of the webinar. I welcome you all. A very warm welcome, and I would like to invite the convener of the program, Dr. Deepak Gupta, who is Additional Director, Medical Oncology at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, for the welcome and introductory note. Over to you, sir.
Thank you and welcome all the faculties and audience. Yesterday, we had a very exhaustive discussion on breast and gynec malignancies with the focus on ovary and endometrium. And I hope we could learn something new to implement in our clinical practice. So today's focus will be on lung cancer basically and GI with a clinical pulse from the ELCC 2026, and in GI it will be from ESPO GI update. So I hope the timeline will be maintained today also. And welcome again, and over to you to start the session.
Sure, sir. So, as we move ahead for the first session, I would like to invite Dr. Tasneem, who is Associate Consultant Medical Oncology at Head and Neck Cancer Institute of India, Mumbai, for the talk on learnings from ELCC 2026. Over to you, ma'am.
Thank you for the introduction. I'll just share my screen. Give me 1 minute.
Yeah,
Okay. So we're going to talk about what came on new in lung cancer in the European Lung Cancer Congress in 2026. So basically, I'm going to talk about 5 trials, 2 being phase 3 studies, which are obviously more impactful and practice changing, while 3 being phase 2 studies, which are guiding us towards a better phase 3 trial in that area. So the first trial I'll be talking about is the role of SASI in patients who are EGFR mutated non-small cell lung cancer and patients who have already progressed on the current TKIs in this space. So SASI is basically a TROP2 ADC with a unique bifunctional linker that maximizes delivery. Give me 1 second. Not able to get the screen out. Okay, anyway, so I'll just continue. So it is basically an ADC which binds to the TROP2. What they did in this trial is they took patients who have already progressed, having EGFR mutation, progressed on prior combination of sequential treatment with platinum-based chemo and EGFR mutant targeted drugs, and they were randomized into 2:1 fashion and given SASI versus docetaxel. The primary endpoint of this trial was ORR, secondary endpoints were PFS, OS. I'm not able to switch also.
Ma'am, can I share?
Yeah, if you can share. I'm actually not able to operate anything on my screen. I have no idea why. It did switch. Okay, give me 1 minute. I don't know what changed. Okay. So the patients were very well randomized. Median age was around 50, so relatively young patient. Good performance status patients with a PS of 1. Brain metastasis around 20%, so not very small number. Most of them were either a 19 deletion or a L858R EGFR mutation. TC790.
Your slides are not matching. Please change the slide. Now, yeah.
I am able to see this slide only.
Yeah, now it's okay.
Right now, what slide? So PFS, yeah, okay. So coming to one of the primary endpoints, which was progression-free survival. So when we compared docetaxel to SASI, it was 7.9 versus 2.8 months. So a very good PFS benefit at 1 year. At 1 year, when we look at overall survival, again, the benefit was quite good, 13.5 months with docetaxel versus 20 months with SASI. Now, the second part, this is the overall survival curve adjusted for crossover. So, amongst the patient who got docetaxel, 41% received a subsequent SAS. In spite of that, the survival curve is way better for SASI. So that means that introducing SASI in early lines is better than introducing after docetaxel. So docetaxel overall survival was 11.2 versus SASI around 20 months. Safety signals, even in spite of giving SASI, the grade 3 side effects were way lower with the SASI group versus docetaxel. Amongst the side effect, neutropenia was the highlighted side effect, and most of them were due to docetaxel. ILD and pneumonitis due to SASI were reported around 2.2% of patients. So to conclude, SASI continues to demonstrate clinically meaningful and statistically significant improvement in PFS and OS compared to docetaxel. And
Dr.
this is
Tasneem,
currently, yeah.
I think you are seeing your slide set and he's sharing another slide set. So it's not matching
Oh,
with the presentation.
okay, one second. I think, yeah, now I got it. I'm so sorry. I have no idea what's the issue. Give me 1 minute. Yeah, I think you can you just reshare?
Ma'am,
Move
my
ahead.
slide.
Go ahead.
Okay, sir.
Go to the next. I've already spoken.
Ma'am, you have to just say next slide. So because
Yeah, I'll do that. But you need to go like a few next. Next, I've already spoken about this.
next slide, go.
Yeah. Next slide, please. Next slide. So basically, the last trial told us that SASI is the new standard of care option compared to docetaxel in a patient who is EGFR mutated, already been given platinum-based chemo and anti-EGFR therapies. The second trial was a phase 3 study called Latify trial. It's a negative trial which looked at the role of siralasertib plus durvalumab in patients with metastatic NSCLC that have already progressed after a immune-based and platinum-based chemo regimen. Next slide. Next slide, please. Yeah. So how does siralasertib work? It is basically a selective ATR DNA damage response kinase that causes checkpoint disruption, fork destabilization, and accumulation of DNA damage. It basically is one of the mechanisms that makes a tumor resistant to immunotherapy. So the idea behind it was that we try to use a drug which will target the resistance mutation and see if are we able to get a response to immunotherapy again. So all of these patients were eligible for a second or third line treatment following progression on or after a platinum based chemo and a anti-PD-L1 therapy, which was either concurrent or sequential. They were randomized into 1:1 fashion with siralasertib plus durvalumab versus docetaxel. The primary endpoint was overall survival. Secondary endpoint was PFS, ORR, and duration of response. They were stratified based on the ATM protein, whether less than 25% or more than 25%, ATM alteration, presence or absence, histology, squamous or non-squamous, PD-L1 expression, and resistance to prior anti-PD-L1 therapy. Next slide, please. So the key baseline characteristics, both of them were pretty similar. Age group around 66 years. Disease stage, most of them were metastatic stage 4 cancers. Prior lines of therapy, most of them had received, around 99% had received at least one line of therapy, and close to 25% had received at least two lines of therapy. Amongst the PDL1 expression level, most of these patients were PDL1 negative with a less than 1% score, and resistance to prior PDL1 was acquired in maximum cases and it was not primary. Next slide, please. So coming to the primary endpoint, which was overall survival, it did not show any benefit. The hazard ratio was 0.90, 10 months versus 11.1 month in the ceralasertib plus durvalumab group. Next slide. It's a forest plot showing the same thing. Next slide, please. Amongst the secondary endpoint, coming to progression-free survival, again, no benefit, hazard ratio of 0.87. In both the groups, the PFS was around 4.1 months. Next slide, please. The next slide is a forest plot showing the same thing, wherein there is no benefit in either of the groups, be it a ATM1 protein presence, non-presence, and in terms of responses, again, there was no added benefit with ceralasertib plus durvalumab when we have compared that with docetaxel. Next slide, please. Coming to one more secondary endpoint, which is duration of response. So here there is some change that we are seeing in this group, where ceralasertib plus durvalumab, the median duration of response is around 6.9 months versus docetaxel, which is 4.4 months. But having said that, there was no PFS benefit, there was no OS benefit. So this still remains a negative trial, and this combination where we are trying to overcome a immunotherapy resistance mutation still remains debatable. Next slide. Next slide, please. We already spoke about this. Irrespective of the ATM protein loss expression, less than 25, more than 25, the grade, all of it remains the same. There is absolutely no benefit of trying to target a resistance mechanism and reintroduce immunotherapy again. Next slide, please. So we spoke about this. Latify did not meet its primary endpoint, and it did not demonstrate a statistically significant improvement in OS compared to docetaxel. PFS and ORR were also not improved. OFS and PFS was consistent across pre-specified group. Next slide. Coming to the third trial, all these three trials are phase 2 trials. What this trial is doing is looking at the role of SBRT followed by durvalumab in early stage non-small cell lung cancer. So they have, next slide, what they have done in this trial is they've basically taken a cohort of patients who are not eligible for surgery. If you look at the inclusion criteria, most of them are not eligible because of the age, and these patients are all T1A or 1B tumors, and they have been exposed to SBRT followed by durvalumab. Next slide, please. Yeah. So, like I said, T1, T2, N0, M0 tumors, all less than 5 centimeter, PS of 0 to 2. They were given SBRT plus routine follow-up or SBRT plus durvalumab for 1 whole year, once a week. The primary objective was time to progression. Secondary objective was disease-free survival, overall survival, local control, and quality of life. Next slide, please. So inclusion criteria, histological or cytological diagnosis of a non-small cell lung cancer, T1, T2 tumors, we already spoke about it, any tumor which is less than 5 centimeter, peripheral tumors were preferred, medically inoperable patients or patients who are refusing surgery, and received no prior chemo or radiation therapy and good performance status. Who were excluded? Patients with a bad PFT, because radiation becomes a contraindication in such patients. Any patient who is on steroids of more than 10 milligram or autoimmune disorder, because we'll not be able to give Durva to those patients. And centrally located tumors, because SBRT technically becomes challenging for centrally located tumors. Next slide, please. So this is the patient characteristics. It was equally divided between both the cohorts. Next slide. I'll just run past in the dearth of time. So coming to the treatment, time to treatment progression, patients who received durvalumab did way better than patients who were only observed after SBRT. Next slide, please. The disease-free survival was the same, overall survival was the same. So there was no difference between OS and DFS, but the time to treatment progression, that is the time where metastatic disease developed or the patient reoccurred, was delayed when we added durvalumab versus no durvalumab. Next slide, please. Amongst the adverse effects, skin reaction, pruritus, elevated liver enzymes, fatigue, thyroid abnormalities were the most common side effects, which we all are very aware that immunotherapy related issues have been primarily this more often than not. Next slide. So adding Durva to SBRT appears to reduce tumor progression. Clinical value in this frail population with high competing mortality remains still uncertain because no DFS or OS benefit. Next slide. This again is a phase 2 trial. It is basically a proof of concept. What they have done is they've taken patients of advanced or metastatic KRAS G12C mutated non-small cell lung cancer and given them adagrasib with pembrolizumab, and they have selected a group of patients which are PDL1 more than 50%. So patients where we expect immunotherapy to work, and they have blocked the KRAS pathway as well along with immuno. Next slide, please. I'll just run through the last two trials quickly. Next slide, please. We'll go quick. Next slide. Next slide. So normally currently in this space, what we are doing currently is that if we find a patient like that, we are giving pembro and chemo or minus chemo as the first line, and we are using sotorasib or adagrasib as a second line treatment. So this trial is practice changing in a way where they are trying to introduce the KRAS inhibitors as first line itself. So we discussed about what group of patients they have taken. And it is a phase 2 trial, it is not a phase 3 trial. And we want to know is that does this combination work? And the follow-up was around a year, which is around 10.1 months, so close to a year. What we found was that overall response rate was 63%, which is quite high. Median PFS has still not reached. Next slide, please. Next slide.
Sorry to interrupt, ma'am. Please conclude in 1 minute.
Yeah, and that's what now I want the slides to actually swipe through. So we spoke about the overall response rate around 63% for this combination. The 12-month duration of response rate was around 83%, which is quite good. If 83% of patients are doing well at 1 year, means it is a combination that is working very well in this space. Next slide, please. PFS not yet reached, OS not yet reached. Next slide. Next slide. Next slide. Next slide. So this is the last trial that I'll be talking about. Again, a phase 2 trial. What they have done is they have taken patients of metastatic EGFR mutant population, and they have exposed these patients who were given osimertinib to a local RT, consolidative RT they have called it, and they have seen whether there is any benefit of doing it. So when we look at the progression-free survival, there is a difference in curve when patients were given a consolidative RT. So 17.5 months versus 25.
I think Tasneem ma'am ka is
Yeah,
locked
I
on.
think she has lost connection. So I think you should conclude and move on to next.
Okay. Now we welcome Dr. Neha Rawat. She is consultant medical oncologist. Okay, ma'am has joined. Tasneem ma'am has joined. Again.
That's it. I just want to conclude. Amongst the 5 trials, some practice-changing trials, and we should be considering consolidative RT in patients who we are able to give osimertinib. That itself is a small cohort of patients. So that was my last trial that I wanted to present. Thank you so much for the opportunity, Dr. Deepak, and looking forward to the further sessions.
Thank you, Dr.
Tasneem.
Tasneem.
Thank you. Now the next session is sponsored by Pfizer, presented by Dr. Neha Rawat. She is consultant medical oncologist, SDMH Hospital, Jaipur. Over to you, ma'am.
Thank you. Thank you for the introduction. So, you would share or I should share?
I'm just here. If you want to share, then you can share.
You can share. I'll ask to change the slide.
Okay, ma'am.
Daud, stop sharing this.
Okay.
Ma'am, my screen is visible.
It's coming.
Yes,
Yeah.
yes. No, yes,
Okay.
it's visible. So, good evening, everyone. Now I'm talking about the ALK rearranged NSCLC. So, first line management of ALK rearranged
Neha,
NSCLC.
you
Hello.
have 72 slides in 15 minutes.
Sir,
So please
no.
move fast.
Sure, sir. Next slide. So this is the table of the contents. Next slide. Next. So as per Globocon 2022, the most common lung cancer is the 4th most common cancer diagnosed in India, and lung cancer with distant metastasis in males is 44% and in females is 47%. Next slide. So when we talk about the mortality, the estimated death rate is 7.8% of all cancer-related deaths with lung cancer. Next slide. So incidence of ALK mutation. So ALK gene rearrangement in lung adenocarcinoma is second most common, 1.62. The range is 1.6 to 11.7% in SCLC. Targetable genomic change after EGFR. And one other that LCMC cohort says EGFR 23%, KRAS 25, and ALK is 7.9%. Next slide. So the ALK rearrangement in lung cancer, basically it occurs in adenocarcinoma histology, and it is around 5% of all NSCLC. Typically, non-smokers or light formal smokers tend to occur in younger patients, and sensitive and specific diagnostic techniques are available. It is EML4, ALK, and EGFR mutations are mutually exclusive. Next slide. So about the discovery of EML4 ALK fusion in NSCLC. So what is EML4 ALK in NSCLC? This is an inversion type of gene rearrangement that occurs when a chromosome is broken in two places, and then again the resultant piece of DNA reversed and reinserted into the chromosome. So the EML4 and ALK gene fusion occurs, and it is reported first in 2007. Next slide. So the unmet need in ALK positive NSCLC, it occurs in ALK positive NSCLC patients are generally young patients, non-smoker or light smokers. CNS metastasis occur in 20 to 40% of patients. So it leads to patient for poor prognosis. And the challenging part for the treatment is ALK resistance mutations and CNS metastasis, that is due to inadequate penetration of the drugs, and a durable control of brain metastasis, and preventing brain metastasis in those without them at the point of diagnosis. And 1 in 3 patients do not receive second-line treatment despite development of second-generation ALK targeting gene agents with improved efficacy. Next slide. So ALK positivity in brain mets in a newly diagnosed patient with ALK positive, incidence of brain mets is around 20 to 30%. The international guidelines recommend testing for CNS metastasis at the diagnosis with MRI. Several ALK TKIs have been evaluated for first-line setting for ALK positive NSCLC with baseline CNS mets and demonstrated prolonged PFS and intracranial efficacy. The lorlatinib is a kinase inhibitor indicated for the treatment of adult patients with metastatic NSCLC whose tumors are ALK positive and detected by an FDA-approved test. And in the first-line setting, lorlatinib has the potential to manage and prevent the emergence of CNS metastasis in ALK positive NSCLC patients. Next slide. So cumulative incidence of brain metastasis with oncogene addicted metastatic NSCLC are like 3-year cumulative brain metastasis is 58.4% ALK, and baseline brain metastasis 23%. Next slide. So to choose the first agent, we have to consider overall efficacy, overall survival, what is the available second line, CNS activity, response rate, and progression-free survival. Next slide. So now about lorlatinib, the drug design and mechanism of action. Next slide. So lorlatinib is the third generation ALK TKI. It is selective, ATP competitive, highly potent third generation ALK TKI. Excellent brain penetration, 75% to address brain metastasis, and improved clinical outcome with overall intracranial activity in patient with previously untreated ALK positive advanced NSCLC. Upfront treatment can completely suppress or at least significantly delay on target resistance, leading to more durable clinical benefit. Next slide. So lorlatinib is designed with to address the unmet needs in ALK positive NSCLC, to address the metastatic brain disease, and to inhibit the acquired resistance to ALK TKIs. So effective CNS penetration and retention, and binds with high affinity to most ALK resistant mutations. Next slide. So the phase 3 CROWN trial. Next slide. So in this CROWN trial, stage 3B or 4 ALK positive NSCLC patients were randomized in 1:1 ratio, and lorlatinib is given 100 mg Q daily, and compared with crizotinib 250 mg BD. The primary endpoint was PFS by BICR, and secondary endpoints were PFS by investigator and ORR. Next slide. So baseline characteristics are comparable. Next slide. So the planned interim analysis in the CROWN trial. Next slide. So the planned interim analysis in intention to treat population showed the primary endpoint of PFS by BICR was met in the CROWN trial. Primary analysis was supported by the secondary endpoint of PFS by investigator assessment. In 12 months, the PFS by BICR is 78% versus 39% with crizotinib, and in PFS in secondary endpoint, the 12-month PFS rate is 80% versus 35% in crizotinib. Next slide. As a 5-year analysis efficacy. Next slide. So after 5 years of follow-up, the median PFS with lorlatinib treatment has not been reached with an investigated assessed PFS rate of 60%. This PFS benefit, which exceeds 5 years, is the longest reported PFS in advanced NSCLC to date. Next slide. So in PFS by investigator assessment in a patient with or without brain metastasis, in a patient both with or without baseline metastasis, lorlatinib improved the PFS with median PFS not reached in either group. Next slide. If we compare it with the Alex trial, the median PFS not reached in with lorlatinib, whereas in alectinib, it is median PFS is 34 months. Next slide. So, time to intracranial progression by investigator assessment in treatment to intention to treat population, lorlatinib delayed the intracranial progression versus crizotinib. There were no intracranial progression events after 36 months. Next slide. Time to intracranial progression via investigator assessment in patient with or without brain metastasis. So lorlatinib delayed CNS progression in a patient with existing brain metastasis and delayed the onset of CNS disease in patient without baseline brain metastasis. So benefit in both groups. Next slide. In compared to Alex, the crown showed benefit in intracranial time to progression. Next slide. Next slide. So, with Crown trial overall and intracranial efficacy by investigator assessment, there is in patient with baseline brain metastasis, lorlatinib resulted in high intracranial response, the majority of which were complete and durable responses. Next slide. So post hoc 5-year analysis association between the depth of response and PFS. So depth of response is defined as best percentage shrinkage of in the tumor compared with baseline. The 80% of patient experienced more than 50% shrinkage in the target lesion, and a higher percentage of patient with baseline brain metastasis was observed with a greater depth of response. Next slide. So in post hoc analysis, the greater depth of response was associated with longer PFS. The probability of remaining progression free at 5 years was 75% in patient with depth of response of more than 75 to 100%. Next slide. Subgroup analysis. Next slide. So in all the subgroup analyses, in the available mutations in the ALK fusion gene, in all the variants, it showed benefit. The lorlatinib activity across all variants, specifically subgroup V3 was the PFS was 60 months in V3 subgroup. Next slide. So the median PFS in patient with TP53 mutation was 51.6 months, demonstrating the lorlatinib activity in difficult to treat population also. Next slide. So Royston pattern. Next slide. These are the Royston patterns with the other TKIs, ALK TKIs like crizotinib, ceritinib, and alectinib. Next slide. So the most common is ALK G1202R, and the lorlatinib is a potent third generation ALK TKI with broad spectrum activity against ALK resistant mutations. Secondary mutations in ALK kinase domain can reduce resistance to first and second generation ALK TKIs, and ALK G1202R confers resistance to available first and second generation ALK TKI, and lorlatinib exhibits broad spectrum activity against most non-ALK resistance mutations, including ALK G1202R also. Next slide. So the sequencing of ALK and ALK TKI generation lead to more ALK resistance mutations. So more generations of ALK TKI, if we sequence them, then we will get more monster ALK resistance mutations. Next slide. So a rationale for upfront use of pan-inhibitory agents. So lorlatinib suppresses the emergence of single ALK resistance mutations. So upfront use of lorlatinib could significantly delay or suppress on-target resistance. Next slide. So this is lorlatinib phase 2 sigma. In the ALK positive patients divided into different experimental arms. Next slide. So the experimental arm 3B, the number of events were very less and median PFS 5.5 months. Next slide. And the resistance mechanism, no emerging new ALK resistance mutations were detected in the circulating tumor DNA collected at the end of lorlatinib treatment. Next slide. The safety profile of lorlatinib. Next slide. When we talk about the safety profile, the adverse events leading to permanent treatment discontinuation were around 11%, and adverse event leading to permanent treatment discontinuation with crizotinib is also 11%. So these are same, and adverse event with lorlatinib are largely manageable with concomitant therapies, temporary treatment interruptions, and raw dose reductions. Next slide. So in Crown and when we compare the Crown and Alex trial, the side effects leading to dose reduction are around 23% and alectinib also 20%. Next slide. So most common grade 3 and grade 4 adverse event in lorlatinib treated group were hypertriglyceridemia, increased weight, hypercholesterolemia, and hypertension. Next slide. So more than 20% of patients treated with lorlatinib are any grade of any grade side effects, and hypercholesteremia and hypertriglyceridemia, both grade 3 and grade 4 are 22 and 25%. Next slide.
And please conclude in next 2 minutes.
So these all side effects are manageable with the dose. Next slide. With the first or second dose reduction, and these are the side effects. Next slide. The safety profile, 5-year safety summary, the lorlatinib safety profile was consistent with that in primary analysis. No new safety signals emerged at 5 years. Only 5% patient discontinued lorlatinib due to treatment-related adverse reactions, and a dose reduction does not compromise systemic or intracranial efficacy. Next slide. So therapy management, next slide. This is the timeline of occurrence of side effects. Next slide. And according to that, the timeline, we can prepare the patient, monitor the side effects, and manage and reassess the side effects. Next slide. So the basic management, basic concept is monitoring, and then if needed, reduce the dose. With first and second reduction, patient will be able to continue the dose. Next slide. Next. So 5-year analysis of efficacy by first dose reduction, next slide, within 16 weeks. So in adverse events seldom resulted in permanent discontinuation and were generally manageable through the dose modification and or standard medication therapy. And the side effects led to permanent treatment discontinuation in 8 patient, 5%, which occurred during the first 26 months. Next slide. So dose reduction did not appear to impact the median PFS. Next slide. And dose reduction did not appear to impact the time to intracranial progression. Next slide. So the first dose reduction is 75 mg OD, then second dose reduction is 50 mg dose. Next slide. These are the summary of all cause adverse events and outcome associated with lorlatinib dose reductions.
Neha,
So
can you conclude now, please? It's 5 minutes
yes, sir.
over.
So with the dose reduction also, we can continue the therapy, and does not affect the PFS. So next slide, last conclusion slide. Next. So summary. So the lorlatinib is as per NCCN, it is also the category 1 indication, and as it has not reached the PFS, so it is the new standard of care. Thank you.
Thank you, Neha.
Thank you, sir, for patience hearing.
Thank you, Dr. Neha, ma'am. Now we move on to next session, sponsored by Roche. Dr. Ankit Agarwal, consultant medical oncologist, pediatric and adult, hemato-oncologist, GMCH, Udaipur. Over to you, sir.
Thank you, Dr. Deepak sir, once again. And I think without wasting further time, shall I share the slides from my side? Okay, so are my slides visible?
Yes, sir.
Okay. Thank you for having me here once again. Thank you, and very glad to be here. And I think without wasting further time, we'll go to the next topic. Just one more thing. I think Deepak sir, we must give credit to Dr. Neha for covering the entire topic within a very short span of time and very well covered topic. Okay, so shifting the gears from targeted therapy to immunotherapy in lung cancer. Okay, so what I'm going to discuss in the next 20 to 25 minutes is about Tecentriq, and that has come into the market in a subcutaneous form. There has been we have been routinely using Tecentriq as an intravenous infusion form, and we were very comfortable with intravenous infusion Tecentriq, as it was providing a good benefit to most of our patients of lung cancer. Roche has introduced Tecentriq in a subcutaneous form now, which, just like pertuzumab, Phesgo, which was introduced as a subcutaneous form, I think now Tecentriq has come into subcutaneous form, and it should be very comfortable for us to give subcutaneous Tecentriq for our patients, which can help us in decreasing the hospital stay of our patients. Okay, so this is a technique which helps in faster Tecentriq administration option for our patients. That is atezolizumab subcutaneous form. This is the disclaimer. Slides have been provided by Roche. Okay, so the studies that led to the approval of subcutaneous Tecentriq and the timelines are as follows. Now, I think the SCIN 00001 study was the first study that was conducted to determine the efficacy, safety, and the non-inferiority of subcutaneous Tecentriq as compared to the intravenous Tecentriq. Now, IM's SCIN 001 was conducted in two parts. That was the first part was a phase 1b dose finding study, wherein they found that the best dose was an 1875 milligram subcutaneous fixed dose that can be given to the patients to provide an equal efficacy as compared to intravenous Tecentriq, that was 1200 mg. And the second phase of this trial was the phase 3 randomized non-inferiority trial, wherein it was compared to intravenous 1200 mg of atezolizumab, and it was found that the pharmacokinetic profile was equal and the outcomes were also similar, or you can say non-inferior to the intravenous form. So it had a positive readout, and Tecentriq subcutaneous was considered to non-inferior to IV Tecentriq, and it got FDA approval in September 2024 after the second study, that was IM SCIN 002 study, was the results of this study was published. So basically that study, what it did was, it through the help of a patient questionnaire, it tried to assess whether the patient were more comfortable in getting a subcutaneous form as compared to the intravenous form of Tecentriq. So basically the quality, or you can say how satisfied were the patients with the subcutaneous form, that was the primary aim of the IMSCIN 002 trial. And it also showed that over 70% of the patients, they preferred subcutaneous Tecentriq over intravenous Tecentriq. Recently, and about a year back in January 25, India DCGI also gave approval in September 25 to the subcutaneous form, and it is available in the market for routine use of our patients. This is the first PDL1 subcutaneous form immunotherapy that has been approved in India. Let us go to the mechanism, how subcutaneous formulation are being utilized and how do these act. Now, basically, any form of subcutaneous formulation, basically it needs some kind of hyaluronidase enzyme to be associated with the drug, which can cause dispersion of the hyaluron or dispersion of the degradation of the hyaluronan in the skin, that can lead to more dispersion of the drug, and thus larger volumes of administration of drugs. So basically, subcutaneous form of Tecentriq has a recombinant human hyaluronidase, which has been, which basically is a novel excipient, and it has a shorter half-life and transient and reversible effects. Now, basically, the addition of this drug, the addition of this hyaluronidase enzyme, it temporarily and locally degrades the hyaluronan at the injection site, with no changes in the structure, and it providing in the structure providing the macromolecules collagen and elastin. And because of its very short half life, the degradation, it results in a temporary increase in the local subcutaneous dispersion area, which helps you to administer larger volumes of a drug. And after the subcutaneous administration, the architecture of the skin is reformed within 1 to 2 days because of the rapid clearance of recombinant human hyaluronidase enzyme. This is what has been utilized in using or in administering a subcutaneous form of atezolizumab. Now, the IMSEIN 001 trial, as I said, was done in 2 phases. The part 1 was a dose finding study. The part 2 was a phase 3 global multi-center randomized trial, which basically was a trial which investigated the pharmacokinetics, efficacy, immunogenicity, and safety of Tecentriq subcutaneous form versus the intravenous form as a second line in patients with metastatic or locally advanced non-small cell lung cancer. So this is the trial design. Now, the patients who had histologically or cytologically documented stage 3B or 4 NSCLC, immunotherapy naive, failed on first-line platinum-based chemotherapy, ECOG performance status of either 0 or 1, were randomized into 2:1 ratio into 2 arms. One arm was the Tecentriq subcutaneous arm, the other arm was Tecentriq intravenous arm. Subcutaneous dosing was 1875 milligram every 3 weeks. Intravenous was 1200 milligram, the routine conventional dose 1200 milligram every 3 weeks. And the primary endpoint was at the end of cycle 1, they wanted to look at the concentration at the C trough levels, and also the area under curve trough, area under curve levels at from day 0 to day 21. The key secondary endpoints were overall response rate, duration of response, overall survival, and investigator assessed progression-free survival. So basically, both the drugs administered through different routes, whether the pharmacokinetic profile is the same or not, that was what basically this trial intended to prove. And it basically the trough plasma concentration levels was used because this is the concentration level that has been found to be related to the mode of action and is also associated with clinical outcomes. Now, the pharmacokinetic parameters which are important for understanding was the most common or the most important is the trough plasma concentration levels, and it was found that the trough plasma concentration levels of subcutaneous form was considered to be non-inferior to the intravenous form, and it proved a non-inferiority of the subcutaneous form. Similarly, the model predicted cycle area under curve levels was also non-inferior to the intravenous form, ultimately reaching the primary endpoints of this trial. And this was consistent with those observed across all the approved indications, uh, um, be it whether we are using it in non-small cell lung cancer or other malignancies like small cell melanoma, urothelial carcinomas, or hepatocellular carcinomas. Coming to the secondary endpoints like median OS, Tecentriq subcutaneous form and intravenous had comparable efficacy profiles when median OS was also compared. So this proved a non-inferior systemic exposure, resulting in a similar efficacy for both the routes of administration. Median OS was almost the same between the two routes of administration. For subcutaneous form, it was 10.7 months, and for the intravenous form, it was 10.1 months, with no significant differences, a hazard ratio of 0.88. Coming to the median PFS and overall response rate, the trial also showed that subcutaneous and IV form had comparable efficacy profiles in terms of progression-free survival and overall response rate. The median progression-free survival was 2.9 months with the subcutaneous form and 2.8 months with the intravenous form. The overall duration of response was 10.8 and 9.7 with the two different routes of administration, suggesting non-inferiority. Coming to the side effect profiles, also subcutaneous versus IV had similar safety profiles. Although the number of injection site reactions was slightly low in the subcutaneous form, and they were grade 1 as compared to the intravenous form. In the subcutaneous form, 3.2% of the cases had grade 1 injection site reactions, and 1.2% of the cases had grade 2 injection site reactions. No infusion related reactions were reported in the subcutaneous arm, or no new unexpected safety signals were also identified, and this showed that the efficacy and the safety profiles were similar between the two routes of administration. Coming to the administration time, the median administration time was 7.1 minutes for subcutaneous form as compared to around 40 minutes for the intravenous form, reducing the patient's hospital stay, reducing the time which healthcare professional spends time with the patient, improving the resources, improving the overall quality of life of the patient. As you can see, the median administration time for subcutaneous form was 7.1 months as compared to 40 months for intravenous form. And majority of the patients receiving Tecentriq subcutaneous had an average injection time between 4 to 8 minutes. Coming to the other, the second trial, which was a patient-reported preference for Tecentriq subcutaneous, that was the IM-SCIN 002 trial. They showed that approximately 8 out of 10 patients chose Tecentriq subcutaneous form as over Tecentriq IV to continue their treatment with. Now, basically, this was a phase 2 open label trial, which was a crossover form in which patients with PD-L1 positive non-small cell lung cancer patients who were at least 18 years of age, EGFR ALK wild type patients, ECOG performance 0 or 1 were included. PD-L1 was positive in these patients, and they were all chemotherapy naive with randomized to 1:1 arm. So basically, there were patients who were started initially on subcutaneous form of Tecentriq at a dose of 1875 milligram every 3 weekly. They were given 3 cycles of subcutaneous form, then crossover was done to the IV form. And similarly, the IV form later on was given for 3 cycles. The other arm, initial 3 cycles of IV form, then crossover to the subcutaneous form. So every patient was exposed to both subcutaneous as well as intravenous form of Tecentriq, and then the patient's questionnaire, with the help of a questionnaire, the patient's satisfaction level was assessed, and the primary endpoint was proportion of the patients who preferred Tecentriq subcutaneous form versus the intravenous infusion form as assessed by the patient preference questionnaire. The secondary endpoints were patient-reported satisfaction, patient's choice of treatment, safety, including safety of switching between the formulations. The patient's demographic and baseline characteristics were similar between the two arms. This was the trial outcome. The patients, approximately 70% of the patients preferred a subcutaneous form. Predominantly, the reason being requires less time at the clinic, feels more comfortable, and was less emotionally distressing for the patient. That was the reason that was given by most of the patients. Why did they prefer a subcutaneous form of Tecentriq as compared to the intravenous form? Overall, 85% of the patients were satisfied or were very satisfied with the subcutaneous form of Tecentriq, and there were no new safety concerns identified with the subcutaneous form of Tecentriq. 8 out of 10 patients chose Tecentriq subcutaneous to complete their treatment even in the maintenance or even in the continuation phase. 64% of the patients said that it required less time in the clinic, 46% felt more comfortable, and 30% approximately said that it was less emotionally distressing because of the uh, just a subcutaneous route of administration. Similarly, the healthcare professional reported outcomes was also studied in this trial, and it showed that the healthcare professional time and the resources of the hospital were more evenly balanced when subcutaneous form was used as compared to the intravenous form. Now, switching between subcutaneous form and intravenous was also well tolerated with no new safety signals. Overall safety profile was consistent with the established atezolizumab safety profile. Switching was also, regardless of the sequence, was well tolerated, and the likelihood of a patient experiencing an injection site reaction or infusion related reaction even did not increase when switching between subcutaneous and IV or vice versa. So we have a new a formulation of Tecentriq that is in the subcutaneous form that is useful also for our patients to be used, and it has been approved as monotherapy for patients with metastatic NSCLC who have a PDL1 score of at least 50%. And this intravenous infusion was approved with after the IMpower 110 results were published. We also, the second line treatment as assessed by the OAK trial, metastatic NSCLC patients who have progressed on prior chemotherapy, irrespective of the PDL1 status, can be given atezolizumab. Initially, it was approved for as an intravenous infusion. Now you can also use subcutaneous form for your patients if they require monotherapy. And also, the Empower 010 trial has led to the approval of adjuvant atezolizumab in patients who have undergone surgery followed by chemo, and then 1 year of atezolizumab can be given for PDL1 positive patients. You can use subcutaneous form for all these indications. Also, Empower 110 OAK trial and the Empower 010, you can give the benefit of subcutaneous form of Tecentriq to all your patients.
Sorry to interrupt you. Please conclude
Yeah.
in 2 minutes,
2
please.
minutes, yes, yes. So Empower 110 will not go into the detail. We know that final OS analysis in the PDL1 high metastatic NSCLC showed a significant overall survival advantage of 7 months when single agent atezolizumab was compared to chemotherapy in PDL1 positive patients. Similarly, OAK, the second line Tecentriq, irrespective of the PDL1, showed a significant benefit in overall survival as compared to docetaxel. The adjuvant trial, there was a significant improvement in the disease-free survival when atezolizumab was compared to placebo in patients who underwent surgery followed by chemotherapy, especially in the PDL1 positive population. Flexibility and economy, as I said, the time taken to administer IV preparation is around 40 minutes of healthcare professionals, which uses more of resources of the hospital. Decreasing these resources or utilizing more, going for an even balance is also more important. So Tecentriq subcutaneous is a ready-to-use solution and enables further optimization of the cancer services and improvement, and helps in utilizing the resources and decreasing the burden on the hospital. It is a 3 weekly schedule. 1875 milligram is the fixed dose that needs to be used, and it is given as a subcutaneous route for approximately 7 minutes for the first and subsequent injections. Replacing subcutaneous is very favorable in terms of economics and in terms of reducing the hospital resources and utilizing them effectively. It reduces the healthcare professional time by 2/3 and cost by at least 1/3. I think to summarize, 79% of the patients, they chose subcutaneous form over intravenous form. The healthcare professional time was reduced by 2/3 and 1/3 cost were reduced when the data, as per the data, and it is the first PDL1 subcutaneous immunotherapy now approved in India. I think that's it from my side. I thank the organizers. I thank Dr. Deepak sir for having me here, and over to the organizers. Thank you.
Thank you, Dr. Ankit Agarwal. Now I welcome Dr. Sajna Chaudhary, who will be presenting session. And she's consultant medical oncology, SMS Hospital, Jaipur. The session is sponsored by AstraZeneca. Over to you, ma'am.
Hello, good evening, everyone. First of all, thank you, sir, for giving me this opportunity. Organizers, can you please run slides by your side? Hello, am I audible?
Sure, ma'am, sure.
Yes, ma'am, you're audible.
Again, thank you, sir. So starting today, I am here to discuss the medical oncologist perspective on changing treatment landscape in stage 3 unresectable non-small cell lung carcinoma. Next. So the overview of today's discussion is defining the disease complexity in unresectable non-small cell lung carcinoma, the role of concurrent chemoradiotherapy as a standard of care, role of consolidation in improving the outcomes of the stage 3 disease, Pacific trial, and the LORA trial targeting the consolidation with osimertinib in stage 3 unresectable EGFR mutated patients. Next. So the about 20 to 30% of the patient with the non-small cell lung carcinoma have stage 3 disease at initial diagnosis. The locally advanced stage 3 non-small cell lung carcinoma is a heterogeneous disease. It is subclassified into stage 3A, 3B, 3C based on the tumor spread, tumor size, and patterns of the nodal involvement. Stage 3A includes T1, T2 lesions with the N2 mediastinal nodes, T3, T4 lesion with the N1 nodes, and T4 N0. Stage 3B includes T3, T4 lesion with N2 mediastinal nodes and T1, T2 with N3 nodes. And stage 3 includes T3, T4 lesion with N3 nodes. Next. Next. So as we discussed, stage 3 is T4N0 or T3 T4N0 or T1 T2 lesions with N2 nodes, and stage 3B is T3 T4 with N2 nodes and T1 T2 with N3 nodes, and stage 3C is T3 T4 with N3 nodes. And when we look for the OS, the median OS in months is 42 months for stage 3A, 22 months for stage 3B, and it drops down to 11 months only in stage 3C. The 5-year OS is 41% for stage 3A, that decreases to 24% for stage 3B, and it's only 12% in stage 3C. Next. So the current standard of the care for stage 3 disease is there are many options like the sequential chemotherapy followed by radiotherapy, or concurrent chemoradiotherapy, or induction chemo followed by concurrent chemoradiotherapy, or concurrent chemoradiotherapy followed by consolidative therapies. Next. So according to NCCN guidelines for the stage 3 unresectable disease in non-small cell lung carcinoma, when we look at the stage 3B and 3C, 3B that is T4 and 2 and 3C that is T4 and 3, after pre-treatment evaluation with the FDG PET CT scan and the brain MRI with contrast and the pathological confirmation of the N2 and 3 disease, in those patients with the contralateral mediastinal nodes are negative, but the ipsilateral mediastinal nodes are positive, that is T4 and 2, and the disease with the contralateral mediastinal nodes are positive, that is T4 and 3. The standard of the care is definitive concurrent chemoradiation, that is category 1 recommendation by NCCN. When we look in details for the management of the stage 3 non-small cell lung carcinoma, in those patients with the confirmed stage 3 non-small cell lung carcinoma, the treatment should be based on multidisciplinary discussion, and after consultation with the surgeon, when the disease is resectable, that is the complete resection, R0 resection of the primary tumor, and involved lymph node is possible, and the N3 lymph nodes are seems to be not involved by the tumor, and the perioperative 90-day mortality is expected to be low, that is about less than 5%. In those resectable disease, the treatment is followed with neoadjuvant chemoimmuno or neoadjuvant chemo or neoadjuvant concurrent chemoradiotherapy, followed by surgery. And after surgery, those patients with a resected stage 3 lung cancer and those patients who have not received any neoadjuvant systemic therapy, these patients are followed with platinum-based chemotherapy in adjuvant setting. In stage 3 resected cancer, those patients with EGFR exon 19 deletion or exon 21 L858R mutation positive are managed with the osimertinib after platinum-based chemotherapy. And those patients with mediastinal nodes are involved but without extracapsular extension and who have received neoadjuvant or adjuvant platinum-based therapy, these patients should not be followed with postoperative RT. And in case of the unresectable stage 3 disease, who are medically or surgically inoperable, but the PS is good, these should be treated with the concurrent chemoradiotherapy. The concurrent chemotherapy part should include a platinum-based doublet, that preferably cisplatin etoposide or carboplatin paclitaxel or cisplatin pemetrexed in case of the non-squamous non-small cell lung carcinoma or cisplatin vinorelbine. In concurrent radiotherapy, RT is given up to 60 gray or in selected patient can be given up to 70 gray. And after concurrent chemoradiotherapy, when the disease is not progressed, there is no disease progression, then these patients with the EGFR exon 19 deletion or exon 21 L858R mutation should be consolidated with osimertinib, or in those patients with the PTL1 positive and EGFR negative are consolidated with durvalumab for up to 12 months. And those patients who are unresectable stage 3 patients with not candidate for the concurrent chemoradiotherapy but are candidates for the chemotherapy should be given sequential chemotherapy followed by RT. And those patients who are not candidate for chemo in any form, that are treated with the RT alone. Next. So the role of the consolidative therapy in improving the outcomes of the unresectable stage 3 is shown with the various trials. The drugs are treated in drugs are treated like the consolidative chemotherapy or radiation or the targeted therapies are tried. In HOG trial, they consolidated with the docetaxel. In KCSG trial, they consolidated with the docetaxel and cisplatin. In PROCLAIM, the cisplatin pemetrexed and cisplatin etoposide is compared with concurrent chemoradiotherapy. In RTOG 0617 trial, the 60 gray versus 74 gray of concurrent chemo RT is given. And the targeted therapy trials like the consolidation with the jeftinib or consolidation with cetuximab is given, but all these shows there is no significant survival benefit with these consolidative therapies. Next. Next. So the outcomes in the patient with the unresectable stage 3 NSCLC based on the PACIFIC trial. Next. The trial design of the PACIFIC is the patient with the stage 3 locally advanced unresectable NSCLC who have not progressed following definitive platinum-based concurrent chemo-RT after 2 or more cycles. Age of the patient should be 18 years or more, WHO PSA score of 0 or 1, and the estimated life expectancy of 12 weeks, more than 12 weeks. And within 42 days of giving post-concurrent chemoradiotherapy, patients are randomized into 2:1, stratified by the age, sex, and smoking history. So the durvalumab arm is given 10 mg per kg durvalumab every 2 weeks for up to 12 months, and the sample size is 476 patients. And the placebo arm, the sample size is 237, and placebo is given for 12 months. The co-primary endpoints of the PACIFIC is PFS by BACR and the OS. And the key secondary endpoints are overall response rate, duration of response rate as per BICR, and the safety and tolerability. Next. So when we look for the outcomes in terms of overall survival, the median OS is 47.5 months with durvalumab and 29 months with the placebo, and the hazard ratio for death is 0.72. So when we look at the Kaplan-Meier curve for the OS, At the 5 year, the OS is the probability of surviving is 43% with the dual map and 33% with the placebo. Next. Show the dual map demonstrated overall survival of 43% OS at the 5 year. Next. OS benefit is seen on the all pre-specified subgroups, but in the patient with the EGFR mutation positive, the gain is not so much. It's about same as placebo. And the patient with the less than 1% PDL1, also there is not so much of gain. Next. So outcome in terms of the PFS, the median OS is outcome in terms of the PFS is 16.9 month with the dual map and 5.6 month with the placebo and hazard ratio of 0.55. And at the 5 year, according to Kaplan-Meier for the PFS, the patients with the free of progression at 5 year are 33% with the dual map arm and 19% with the placebo. So dual map shows the sustained and durable PFS of 33% benefit at the 5 year. Next. Next. PFS benefit is seen in the all pre-specified subgroups but not in the patient with the EGFR mutation status. It's same like as placebo and in PDL1 less than 1%. Next. So according to Pacific and the various Pacific R and RW studies, those in patient with the EGFR mutation positive patients, when we look for the median PFS in the dual map arm is 11.2 months and 10.9 months in the with the placebo in EGFR mutated patient with a hazard ratio of 0.91, and the median OS is 46.8 months with the dual map arm and 43 months with the placebo with hazard ratio of 1 in EGFR mutated patients. So it shows that giving dual map is not of worth in patients with the EGFR mutation. Next. And when we look for the outcomes in the patient with the unresectable stage 3 non-small cell lung carcinoma, EGFR mutated patients based on the LAURA trial. LAURA is phase 3 double-blind study trial. Patients with the locally advanced unresectable stage 3 EGFR mutated NSCLC with the no progression during or following the definitive concurrent chemoradiotherapy treatment. The key inclusion criteria of the LAURA is age should be 18 or more than 18 years. In Japanese population, it should be more than 20 years. WHO PS of 0 or 1. There is confirmed locally advanced or unresectable stage 3 NSCLC. And the patient should be positive for exon 19 deletion or ALAT5A mutation. And the maximum interval between the last dose of concurrent chemoradiotherapy and randomization should be 6 weeks. Patients are randomized in 2:1, stratified by the either concurrent or the sequential chemoradiotherapy is given, stage 3A versus stage 3BC, Chinese or non-Chinese population. Osimertinib is given at 80 mg OD dosing, and the treatment duration until BICR or other discontinuation criteria. In this, the open label osimertinib after BICR confirmed progression is offered to both the treatment arms. Tumor assessment is done with the chest CT or MRI and brain MRI. These tests are done at the baseline and every 8 weeks to the week 48, and then every 12 weekly until BICR assessed progression is noticed. The endpoints of the LAURA trial, the primary endpoints are PFS assessed by BICR, and the secondary endpoints includes OS and CNS PFS and the safety profile. Next. So according to BICR, the progression-free survival is highly significant benefit is seen. Then when we look at the Kaplan-Meier curve for the PFS, there is early separation of the curves with the 2-year PFS of 65% with the osimertinib with a hazard ratio of 0.16. When at the 2 years, there are 65% are progression-free with osimertinib in compared to 13% only with the placebo. The median PFS in months is 39.1 month with osimertinib and only 5.6 month with the placebo with the hazard ratio is 0.16. Next. This forward. And this PFS benefit is seen across all the subgroups. And it's somewhat better in the stage 3B and 3C in compared to stage 3A. And in both exon 19 and exon L858R mutation, and both Chinese and non-Chinese population, but somewhat less in Asian population in compared to non-Asian. Next. The PFS, the progression-free survival for CNS events in osimertinib arm, there are about 20% of the total CNS PFS events are noticed, and in 41% of the patients with the placebo arm develop CNS events. The median CNS PFS in months is not reached in the osimertinib arm, and it's 14.9 months with the placebo arm with a hazard ratio of 0.17. So there is early separation of the curve with a reduced risk of CNS progression or death is noticed with the osimertinib with a hazard ratio of 0.17. When we look at this Kaplan-Meier curve, at 2 years, the probability of CNS progression free is 83% with the osimertinib and 43% with the placebo. Next. So, osimertinib reduces the risk of the CNS progression or death with osimertinib, with about 41% patient in the placebo experience CNS events and only 20% with the osimertinib. That shows that osimertinib shows a significant CNS protective effect with a hazard ratio of 0.17. Next. When we look at the cumulative incidence of the events, the cumulative incidence rate of CNS progression is at 12 months is 9% with the osimertinib and it's 36% with the placebo. Next. The time to distant metastasis or death, that is TTDM by the BICR, means that those patients who have not experienced the event of the interest by the time of the data cutoff or when lost to follow-up, TTDM, these patients are alive and free of the distant mets at the last follow-up. So there is clinically meaningful improvement in TTDM is noticed with the osimertinib in compared to placebo. That about the median TTDM in months is not reached for the osimertinib and it's 13 months with the placebo with the hazard ratio of 0.21. At the 2-year, 81% of the patients are distant metastasis free in compared to 43% with placebo and 81% with the osimertinib. So it shows that osimertinib have ability to delay the distant mets, which is most common complication of the post-concurrent chemoradiotherapy receiving patients in EGFR mutated cancer patients. When we look at this safety profile, any adverse events of grade 3 or more are noticed in 35% of the patient with the osimertinib and 12% with the placebo. And any adverse event that leads to treatment discontinuation are observed in 13% of the osimertinib arm and 5% with the placebo. Next. The adverse events that are reported in the trial are in both arms. That is most common is radiation pneumonitis, but majority are of low grade, not grade 4 and 5, and these are non-serious and manageable. That's about 48% of the osimertinib arm have radiation pneumonitis and 38% in the placebo arm. Second one is diarrhea that is occur in 36% patient of the osimertinib arm and 14% in the placebo, followed by the rash and other side effects like the paronychia, cough, decreased appetite, dry skin, pruritus, neutropenia, and pneumonia. ILD is reported in 8% patient in the osimertinib arm, and majority are the grade 1 and 2 and easily manageable. Next. So the current treatment guidelines to manage the unresectable stage 3 disease in non-small cell lung carcinoma according to NCC and ASCO and ESMO guidelines. So the stage 3, that is T4N0 unresectable, or stage 3B, that is T1 to T2 and 3 nodes, and T3, T4 with the N2 mediastinal nodes, and stage 3C, that is T3, T4 with the N3 nodes, is definitive CTRT, and followed by consolidated durvalumab or osimertinib in EGFR exon 19 deletion or L858R mutation. According to ESMO and ESMO guidelines, these recommend EGFR mutation testing, PDL1 expression testing, and now as adjuvant alectinib is also available, ELK testing also. Next. So the current scenario for the prevalence of the stage 3 non-small cell lung carcinoma that accounts for 30% of the all non-small cell lung cases, and this majority are unresectable. And the concurrent chemoradiotherapy remains the standard, offering median OS of 17 to 28 months, depending on the ECOG-PS of the patient and their tumor staging. The Pacific trial shows a 16.8-month versus 5.6-month PFS, and the hazard ratio for OS is 0.72. That shows the dual map establishes as a standard post-concurrent CTRT in patient with a PDL1 more than 1% and driver mutation negative. LAURA trial in EGFR mutation patient shows the median PFS of 39 months versus 5.6 months with a beautiful hazard ratio of 0.16 only, supporting osimertinib as a new consolidation option in patients with EGFR mutated patients. So the current treatment guidelines according to NCCN recommends PDL1 testing and EGFR mutation testing, post-concurrent CTRT, and use of osimertinib and durvalumab as we discussed above. Thank you. Thank you for patience listening.
Thank you so much, Sachna ma'am. Now the next session will be of Dr. Tarun Durga. This session is sponsored by MST. Dr. Tarun Durga is Associate Director, Medical Oncology, Medanta Hospital, Noida. Welcome, sir.
Hi.
Just a minute. Support team, please stop the recording.
Yes.
Should I start?
1 minute, sir. Support team, is the recording stopped?
Yes, ma'am.
Yeah. So you can go ahead.
Okay. Next slide. Should I be presenting or the slides would be
Sir,
presented?
any which ways, which is comfortable to you, just let us
I
know.
think I'll share the slides. Give me a sec.
Sure. Sure.
Yes, okay. So this is a sponsored session from sorry, why is this thing not going? Just a sec.
Yeah, your screen is visible, sir.
So this is session sponsored by MSG. So I'll be running through a few slides. So we all know that lung cancer is the fourth most common cancer, both with incidence and mortality. When we look at the treatment paradigm, it has changed significantly over the last 20 years. There has been improvement with addition of targeted therapies, which came in India around 2009 onwards. And then by around 2015-16, we had the immunotherapies which took over. So we now have different modalities by which we treat lung cancers, targeted and immunotherapies. Now, this is the first case that I'll be talking about. It's a 78-year-old gentleman who presented with multiple lung nodules. He was diagnosed with the lung cancer initially and then progressed to stage 4. I'll be talking in detail about him. So initial presentation was a small 1.9 into 1.7 centimeters lung nodule in the left lower lung. SUV was low, it was 2.63, and CTs also collaborated with the same findings. Initially, it was diagnosed as T1N0 lung cancer, and there were other few inflammatory nodules. Apart from that, it was discussed with the family whether resection should be done, and an FNAC. The family refused for treatment or to go ahead with an FNAC either. Subsequently, the lung nodules increased in size. The patient developed a left lower lobe nodule, which was 2 centimeters, and another right upper lung nodule, which was stable as such through the serial scans. The patient was offered radiotherapy. I'm skipping through the slide. The patient was offered SPRT to these lung nodules, and he did well initially. But on follow-up, there was progression with disease progression both in the sacrum, liver, and nodes. At this point of time, there was discussions between the surgeons, radiation oncologists, and medical oncologists, and unsurprisingly, the surgeons were not keen to go for any surgery. The radiation oncologists also did not feel that all these sites could be treated, so it was left to the medical oncologists to treat it with targeted therapies. At that point of time, initially when we had the tissue, we did not have enough tissue to know about the PDL, ALK, EGFR status. So new tissue was taken from the sacral area and it was found to be a sarcomatoid metastasis. And at that point of time, palliative radiotherapy was given to the vertebral lesions, and the patient was started on immunotherapy. In view of age and patient choice, the patient was started on single agent pembrolizumab. The PDL expression was high. The patient responded very well to the therapy. Uday, I'm on the presentation. Hello, can you hear me? I'm in the presentation. Okay. So at this point of time, the immunotherapy did have fantastic response both in the lungs and in the metastatic sites. And the patient went on to receive the treatment. And interestingly, as per the guidelines, initial treatment recommendation was for 2 years, but in this patient, the treatment was given much longer. And the patient has been disease-free, not disease-free, has been with well-controlled disease more than 7 years post initial diagnosis.
And 8.3 months in the high risk. When we compare the median OS in the other treatment group, it was 13.67 months versus 4.7 months. So it was still definitely better when you stratify from the disease biology also. Next slide. This is similar that adverse event profile basically actually versus chemo versus immune related side effect. Next slide. So coming to the conclusion of rational 307, within the limitation of retrospective analysis, Licuzumab TBP might bring survival benefit for squamous cell carcinoma patient. Patients with low or intermediate risk tended to have a longer overall survival, suggesting a potential benefit population that need further investigation and offer insight for clinical decision making in TBP. This finding need to be confirmed in a larger prospective study. Next slide. So this is the real world study, which is again Chinese-based study, which was done post the retrospective analysis of Silujumab in lung cancer population of non-small cell lung cancer, EGFR ALK negative, and patient received tislelizumab monotherapy plus chemotherapy plus anti-agenesis plus chemo plus anti-agenesis. So they analyzed around 370 patients. Out of them, 48 patients are still ongoing treatment, but almost majority of patients did receive tislelizumab plus chemotherapy. Next slide. So these are the patient characteristics, which is basically similar to our Indian population, majority male, more than 65, PS is 1 or more, and PDLL expression is also heterogeneously positive. More than 15%, only 21% patients were there. Majority patient were smoker. Histology was squamous and non-squamous, very similar. Majority patient was stage 4. Next slide. So as we can see that there is good disease control rate was seen in this study, and overall response was 56.54%, which was seen. And at 3 years, the 20% overall, 12% overall survival was there. PFS was there. Next slide. And this is the similar thing that data was mirroring the study. Next slide. So this is the Kaplan-Meier for histology, and compared to the PD-L1 status, we do know that if PD-L1 is high, the response rate and PFS is better, but still the data was similar to the all other standard clinical trials. Next slide. This is the 4 treatment strategy that this other patient is tislelizumab alone, tislelizumab plus chemo plus angio. So maximum benefit was there when patients received all the 3 agents, and those patients benefited the most. Next slide. So coming to the conclusion of this real study, this was the largest real world analysis from Silujumab that it can be delivered as a first line therapy with a durable PFS across all patient subgroups, and the clinical benefits are observed in patients with PD-L1 high, non-squamous, non-small cell lung cancer. Next slide. Coming to the second study, that rational 305. It was also
Dr.
phase
Jitendra, sir, a great meeting and great discussion, but you have last 2 minutes to conclude, sir.
Sure, I will. So this was on adenocarcinoma subtype. Next slide. So this was a study design. Patient received platinum chemotherapy with pemetrexed, and then tocilizumab maintenance along with pemetrexed was given. Next slide. So this was a PFS with an hazard of 0.73, means 37% of risk reduction was given. Next slide. So overall response is also better with the addition of tocilizumab, and the two-stage model suggests that median overall survival was 21.6 months versus 14.9 months. Next slide. Coming to the third data, which is third line tocilizumab versus docetaxel, rational 303. Next slide. These patients were exposed to platinum and were randomized to tocilizumab versus docetaxel, and then tocilizumab continuation was given. Next slide. So here also we can see in the second line also the data was strong and it was almost equivalent. And at 24 months there was a delta of around 13% in overall survival when you use tocilizumab versus docetaxel. Next slide. So this is the 5-year OS data. At 5 years, tocilizumab around 20% overall survival, which is mirroring the single agent pembrolizumab data. Next slide. So this is the efficacy subgroup analysis, and it was consistent benefit over docetaxel across all PDL1 subgroup was seen. Next slide. So this is efficacy that PFS was slightly better. Here overall response is also better than we compared to docetaxel, which was not seen in other immunotherapy trials. Next slide. So this is biomarker analysis. They have seen that if patient is Notch14 mutant, probably tislelizumab works better in the upper graph, and those patients were benefited the most. Although it is a food for thought, we need robust data to prove it. Next slide. So this is similar for PFS for Notch14 mutation. Next slide.
Jiten sir, we need to close, sir. I mean, if with your
So
permission.
to conclude, yeah, I will just conclude that tislelizumab is useful in lung cancer along with chemotherapy in first line, and in single agent when patient received platinum doublet in the first line. So it do have approval by DGCI in India. Thanks for the patience.
So thank you so much, Dr. Jiten. Pooja, can you now invite the next speaker?
Thank you, sir. Now the next session is sponsored by AstraZeneca, presented by Dr. Jayashree Goyal. I welcome Dr. Jayashree Goyal. She is consultant medical oncology, BMC HRC Hospital, Jaipur. Over to you, ma'am.
Yeah, thank you, Pooja. I'll be sharing my screen. Wait a minute, please. Yeah, thank you, Dr. Deepak Gupta, and thank you, AstraZeneca, for inviting me to this event. I hope I am audible.
Yes, ma'am.
Yeah. Is my screen visible?
Yes, ma'am. It's visible.
Yeah. So I'll be talking about a new era in managing resectable gastric cancers with durvalumab and FLOT. So this is the outline of the talk. So gastric cancer is seventh most common.
Dr. Jayashree, ma'am, sorry to interrupt. Can you make it a full slideshow?
Sure, sure.
Yeah. Otherwise, the slides are visible and you're perfectly audible. Yeah, please. Wonderful. Please go ahead, ma'am.
Thank you. Yeah. So, as we know, gastric cancer is the seventh most common cancer and the sixth leading cause of cancer related deaths. And adenocarcinomas are the most common histologies with male preponderance. And the 5 year overall survival rate of gastric cancer remains poor, often less than 20%, most commonly due to the advanced stage of presentations and limited access to curative treatments. So, for the management of resectable cancers, for perioperative chemotherapy is usually recommended for patients with resectable stage 1B or higher gastric cancers. Adjuvant chemotherapy is advised if for patients after primary D2 dissections, and post-op chemoradiation is advised if there is less than D2 dissections. And for unresectable gastric cancers, those who are in stage 4, primary systemic therapy is the recommendation of treatment. So, many patients with gastric cancers obviously experience recurrences despite surgery, and around 61% patients experience recurrence post surgery, and 43% of the patients are experiencing recurrence within 2 years of surgery. So, there is a high unmet need of perioperative treatment. So, this was way back with MAGIC trial, where perioperative ECF chemotherapy had shown improved survivals uh, uh, compared to surgery. For just a minute. Compared to surgery alone for patients with resectable gastric cancers or gastroesophageal cancers, and there was improvement in survival outcomes with this trial. So based on this trial, we had flawed 4 studies which compared ECF or ECX versus flawed in perioperative patients who are potentially resectable adenocarcinomas of GE junction or gastric cancers. And this trial included two weekly cycles of flawed, 4 cycles followed by surgery, followed by adjuvant flawed, and the same was for ECF or ECX. The stratification was performance status, age, and the location of the tumor, and the primary endpoint was PAT-CR. So, this perioperative flawed significantly improved the survival with improvements in PAT-CR 16% versus 6% for ECF, and it has given an improvement in median OS and DFS. So, perioperative flawed is now the standard of care, but the major issue was that 60% of the patients could be started on flawed therapy post surgery, and out of these, only 46% of the patients could complete the flawed adjuvant one. So, because of these issues, a modified flawed regimen was analyzed for these types of cancers at Tata Memorial Hospital between 2016 to 18, where they showed that reduction in doses of 5-fluorouracil has resulted in higher completion rates with manageable toxicity and early survival outcomes as compared to flawed AIO studies, and with comparable toxicities, and there was a survival advantage with this trial. Modified flawed, as I said, had better survival outcomes with tolerable safety profiles. So, it has been used as a standard of care. But despite this positive impact, the recurrence rates remains high in patients with this subset of patients. And most of the patients experience disease progression within 5 years following flawed, with an estimated 5 year OS of 45%. So there is an unmet need to identify novel neoadjuvant or adjuvant regimens for these resectable gastric cancers or gastroesophageal cancers. So now we know that immunotherapies have come into practice for metastatic gastric cancers and G junction cancers. And as we all know, the immunotherapy primes the systemic immunity by exposing tumor antigens. So it clears the minimal residual disease, and it builds up the immune memory for a long-term cancer surveillance. So based on this, uh, 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 data, the PDL1 is found in 40 to 60% of gastroesophageal junctions or gastric adenocarcinomas. So it is supporting the anti-PDL1 therapy. And we could even see in a Korean study where high PDL1 patients had significant lower 5-year overall survival as compared to PDL1 low cases. So based on this, there were many clinical trials which investigated the addition of immune checkpoint inhibitors to chemotherapy in these patients. Major were KN585, where Pembro was added to cisplatin plus 5FU, but that did not show an EFS benefit and it was a negative trial. Matterhorn trial, which we will be discussing in this uh, uh, talk later on, which is a positive trial. Then we had the addition of perioperative atezo with FLOT, where the PFS data is awaiting, and Attraction 5, which has included perioperative CT with adjuvant Nivo, but this has been a negative trial. So coming to Attraction 5, so this has added nivolumab in adjuvant setting for operable stage 3 gastric or gastroesophageal cancers, and the primary endpoint was centrally assessed RFS, but this trial did not meet its primary endpoint. So Keynote 585, where addition of Pembro plus chemo versus placebo plus chemotherapy as perioperative therapy was assessed in this phase 3 randomized double-blind trial, which has included previously untreated and locally advanced GE junction or gastric cancers. And this was stratified by geographic region, tumor staging, and the chemotherapy. The chemotherapy arm in the immune checkpoint inhibitor Pembro was either cisplatin 5-FU or FLOT, and there was a placebo arm with cisplatin. The primary endpoint assessed in this trial was EFS, OS, and PAT-CR. So the first interim analysis in addition of pembrolizumab as perioperative therapy did show improvement in PAT-CR, but this did not translate into an immediate EFS benefit, and there was no statistical improvement in OS also as compared to chemo. So overall, it was a negative trial. So next is Matterhorn trial. So FDA has recently approved durvalumab for resectable gastric or esophageal junction cancers. These are operable cancers for perioperative therapy, and AstraZeneca has got a Cedesco approval also for addition of this therapy in gastric cancer treatments. So going to the Matterhorn study design, so it was a phase 3 randomized double-blind trial done on histologically documented resectable gastric or G-junction patients with non-metastatic disease with good performance status. Good addition point was that the trial design was stratified by PDL1 expression, either less than or more than 1%, and presence or absence of clinical lymph node metastasis. This trial, we have given durvalumab every 4 weekly 1500 milligram along with 2 weekly FLOT chemotherapy regimen for 4 cycles, and this was compared with only chemotherapy arm followed by surgery, and then adjuvant treatment was given for a total of 1 year duration. The primary endpoint of the study was EFS, and secondary endpoints were OS and PAT-CR reports. So coming to this trial, basically more than 95% of the patients have completed the chemotherapy or chemoimmunotherapy arm, and more than 90% of the patients surgery could be attempted, and patient could complete durvalumab treatment in more than 52% of the patient. So demographics, baseline demographics and study characteristics were similar between two arms. Most of the patients were, more than two-thirds of the patients were gastric origin. The primary tumor stage was non-T4. 70% of the patient had clinical lymph node positivity, and 90% of the patients had more than 1% PDL1 expression in this type, in this trial. So durvalumab plus FLOT therapy has shown a median EFS, 18-month median EFS was 73% as compared to chemotherapy arm alone, and 24 months EFS was 67% as compared to chemotherapy arm alone, with a hazard ratio of 0.71. So this EFS was favored towards the durvalumab arm in all the subgroups as compared to the chemotherapy arm alone. And the durvalumab plus FLOT has demonstrated a statistically significant improvement in OS compared to the FLOT regimen alone. Yeah. And this benefit is consistent along all the subgroups in the immunotherapy arm. So this already I have shared that there is a benefit in OS irrespective of the PDL1 status. And it has given a significant increase in PAT-CR as compared to the chemotherapy arm FLOT. The difference is more than 12% graph going towards Durva plus FLOT arm. So the same thing, AFS has been improved in the immune checkpoint inhibitor arm with any degree of pathological response. And most of the patients were able to complete the amount of treatment planned at the initiation of the trial. The safety profile for Durma plus plot was consistent with the known safety profiles of the individual agents. The common adverse events were diarrhea, nausea, and neutropenia. Most of them were manageable. So the key takeaway from the Matterhorn trial was the addition of Durva to FLOT has improved the overall and event-free survival in resectable gastric and gastroesophageal junction adenocarcinomas. So just to summarize the presentation, gastric cancer is the fifth most common cancer diagnosed, and it is one of the leading cause of cancer-related deaths worldwide. FLOT4 established perioperative chemotherapy as standard of care, but here the relapse rates remained a major challenge. Immunotherapy combinations in various trials have improved the PATCR, but that did not translate into survival outcomes. But in Matterhorn trial, the improvement in PATCR has has consisted into the EFS benefit also and overall survival benefit also, and this benefit has been consistent across all the subgroups, and there were no major safety concern. That treatment was well tolerated along all subgroup of patients. So Matterhorn, according to Matterhorn trial, Durva plus FLOT is the present standard of care in operable gastric and gastroesophageal junction cancers in a perioperative setting. Thank you.
Thank you, Dr. Jayashree, and thank you for concluding in time.
Thank you, Dr. Deepak.
So, can you stop sharing, please? Yeah.
Yeah.
So, next presentation is by Dr. Bharat Vaswani, who is Clinical Director, Medical Oncology at Yashoda Hospital, Hyderabad. And he will be giving us updates from the ESCO GI 2026. Welcome, Dr. Bharat. Dr. Bharat, are you there?
He's there, sir.
But he's not responding.
Mhm.
Can you just give him a call and ask? Okay, he's
Yeah,
there.
hi.
Hello,
So,
Dr. Bharat.
hi,
Welcome.
Deepak. Very good evening. First, apologies for all these things. I
No
was
issues.
somewhere in a different, I was presenting somewhere else. I finished, I just joined here. Am I audible clearly?
Yes, yes, yes.
And 2 minutes, I'll just share my slides. I just share it. And are my slides visible?
Yes, it is visible.
First, let me thank Deepak. Thank you for a kind invite. This is a topic that I always wanted to discuss, what has come new. And the topic that I'll be discussing in the next 15 minutes is in this ESCO GI 2026, which was conducted, which was there in the month of Jan, what new came out in terms of gastrointestinal malignancy. So if I have to remember, if you can forget everything in this ESCO-GI, the first and the only blockbuster study. Why I call it as a blockbuster? Because it is a practice-changing study. So that was the study's name was Horizon GEA-01. Now, all of us know that in a metastatic GE junction cancer, which is HER2 amplified, we give chemo with trastuzumab. There is some data that in HER2 or trastuzumab deruxtecan is a more potent drug and now is a drug of choice post progression. So this was a drug, zanidatamab, with chemo plus minus a immuno in a first line HER2 positive, locally advanced unresectable or metastatic GE junction carcinoma. So the standard of care they are comparing with a new molecule. So let us understand what is zanidatamab. Look, you have so many molecules. You have a new standard of care, zongertinib, if you remember, in a lung. This is for GI counterpart. So it is a biparatropic antibody. So what is biparatropic? So the antibody which connects two sides of HER2 So by connecting with the two sides, it induces a cell-dependent cytotoxicity and antibody-dependent cell cytotoxicity. So more importantly, it increases the cell death, but it also potentiates immune activation. And here they thought that it comes a synergy. So please remember, as I told you, the treatment of choice is immunochemo. I was wrong because now there is a FDA approval that you add pembro and that is a standard of care. So this was comparing it with zanidatamab. So biparatropic antibody. So because there is a substantial data of one arm, I'm not comparing with a single agent Denny data right now. But again, there was an improvement in terms of PFS in the single alone arm, but the arm which it is more important is with chemo plus IO. So I have underlined something which you have to remember. So unresectable, locally advanced, no prior treatment. That is more important. One arm with trastuzumab chemotherapy with zanidatamab, tocilizumab and chemo. The primary endpoint, absolutely good PFS and OS. So let's see the most important endpoint. Statistically significant and clinically meaningful improvement in PFS. So from 8.1 months, it is 12.4. So around 4.3 months absolute gain with a reduction in the risk of progression by 37%, which was statistically significant. See the P, less than 0.001. So a drug which is probably more potent than standard of care. Now, when you look into the OS, there I wanted to stress on something. 26.4 absolute gain of 7.2 with a risk reduction of 28%. So the reduction in the risk of death by 28%. Now, somebody of you may point out that it could be due to tocilizumab. So I have not put it, but Zeni data with chemo was 24.5 months. So there was a absolute gain of more than 5 months, which had not reached a statistical significance, but yes, it was trending towards it. So head on also, it was very good. And when we combine with immuno, which is a standard of care now, with pembrolizumab data, there was a statistically significant. So yes, we have a standard of care which may change once the drug is available. What about the response rate? Again, a minor improvement from 65.7 with to 70.7, but I would like you to think of duration of response from 8.3 up to 20.7. Think of any drug except for immuno this where you have Tina response duration close to 2 years here. What do you think of side effects when you think of zenidatamab? So two side effects, a more diarrhea and a slightly more hypersensitivity, what they suggested. But when this drug will come, you will be more careful about the diarrhea, which was a common side effect, but it did not lead to treatment disruption. So treatment related side effect was there, but if you see zenidatamab, it was only 11.9 and it was predominantly diarrhea. So no unexpected signal. So yes, a drug once it is available will be probably and is better in terms of PFS 35% reduction, in terms of OS 28% reduction, and more importantly, the safety profile is consistent with that. So there was a audience poll. If you have time, go to Oncology Brothers. Any topic I prepare, I read their thing, Oncology Brothers. So they did a audience poll immediately post day one of ESCO GI. And what did the audience there suggest? 52% said yes. Whenever this drug is available, for all comers, we'll use it as a first line. So my take is Harrison GEA a practice changing study? Answer is a big yes. Zanidatamab will be a new standard of care once it is available. You need to watch out for side effect, that is diarrhea. I will be more interested to get the other arm of single agent Zeni because that arm over a period of time will show whether a single agent will be as good as without adding a IO, but immunotherapy alone will be defined further when we give maybe a 4-year update. For now, if you have to remember ESCO GI 2026, only one data which will make a practice change is a Zeni data map data, that is Horizon. The second data is capital study. Now, what is the standard of care in the adjuvant in India that we use post-operative stomach cancer is capox or folfox. But these East Asian, they use S1. So S1 for 1 year, I need to tell you there is something different. So what if I combine Oxali with S1 in a stage 2-3 gastric or GE junction cancer? So this was a randomized phase 3 study, that is capital study. So post D2 standard gastrectomy, Oxali with S1 followed by S1 for 10 months versus S1 alone for 16 cycle. The most important thing, OS, did it improve the OS? So when I talk about DFS, absolute gain of 11.6% with a reduction in the risk of 20. Look, 20 to 30% is an improvement when you use a oxaliplatin. When you talk about the most important thing, the statistically significant improvement in OS, 8%. 8% is a big number when you add oxali with S1. So toxicity manageable. So probably some skin related things, some diarrhea, but not statistically significant. So what did this drug suggest? Yes, Oxali with S1 statistically improved your OS 8%, your DFS 11.6%, OS benefit across all subgroup, and capital trial probably in that countries it will be the standard adjuvant treatment. What it tells us is it a practice changing? We have already changed. I don't think anybody uses a single agent S1 or capsitable in India. It is a practice reinforcing data because it again reinforces that single agent 5FU is not the standard of care. You need to add platin in an adjuvant setting and a flot in the neoadjuvant setting. So there comes my third data about COMET study. All of us know that in a MSI high type in colon, which is approximately 5 to 10%, in adjuvant stage 3, we had atomic. In a stage 4, we had, the data says that what do you use? Do you use Pembro single agent or do you use a Ipi-Nivo? So the data strongly or heavily favors a dual Nivo-Ipi. Remember your checkmate 8HW study. On that similar line, there is one study which is COMET study, again a phase 3 data, which combines Atizo with a chemo with bevacizumab. So what are we using? Molfox with Bev. We have combined with our immunotherapy partner in a MSI high. So without, so first line data with a Folfox Bev with Atizo versus a Atizofula. 24 months PFS if you use a combination with chemo and atizo versus 5.3 months with atizo. So think of your atizo. I don't think atizo is such a potent drug in colon. Your pembrolizumab is so good, 12 to 16 months. So this is a drug which gives you a good data, again reinforcing that IO has to be used in a first line in a MSI high subset. Toxic at 2 years, the progression-free survival is 53%, and your the CR plus PR or your ORR is 86%. Something which we have never heard of it in a normal colonic patient. Unfortunately, no difference in OS between the arms, and that was due to a high crossover of the patient. So here comes my question. Grade 3-4 toxicity, mostly chemo-related, 82.9, which was mostly due to chemotherapy. So what they suggested is, yes, when you combine your IO with a chemotherapy, there is a significant reduction in the risk of progression, around 55% improvement, a very high CR of 36.1%, but of course with a higher rate of toxicity. So I will not take your answer, but I'll ask you, tomorrow morning, will you use this combination in those with the MSI high? So the answer is no, you will not use this combination. The answer is why. Now, again, it is a sin to do a cross trial comparison, but I will compare it. Do you remember what is your checkmate 8WPFS now? This is a drug at Nivo IP in a high MSI, 65% at 4 years. I repeat myself, 65% at 4 years from 71 at 2 years. So head on, this is the better combination. And if you go through the details, these comet people stopped the trial when they heard about the astonishing results of checkmate 8 So on any day, EP Nuvo is better, but this trial suggests that yes, IO has to be given now. You give it with chemo, which I don't believe, because I'm a firm believer of checkmate 8 which has the abnormally high 64 years. The PFS will be as long as 5 years, as against this trial of 24 months. The fourth study, breakwater study. So tomorrow morning, if you see a BRAF mutant drug, what are you doing? At present, we don't have encorafenib in India, but I give panitumumab with my drug in the, and either a dabrafenib or a trametinib. So dabra, tremi, penny, and chemo I give it because encorafenib is not available. But all the data of breakwater in cohort 1 was with FOLFOX. So this trial in a phase 3 tried to see whether substituting FOLFOX for FOLFIRI is the quantum of benefit the same. So instead of FOLFOX, it was FOLFIRI. So see, first line, BRAF mutant, Encora Cetuxi with FOLFIRI, ORR was the primary endpoint, PFS was by blinded independent central review was the secondary endpoint. A nearly 25% absolute improvement in terms of ORR from a 39%. You have a drug which is 64.4%. I'll go back. So Folfari with Viv versus Folfari with EC. See the dramatic improvement in the ORR, 64.4 versus 39.9. So what was the primary endpoint? Statistically significant and a clinical meaningful improvement in ORR. So hands on a drug which is far more potent, or the combination which is more potent. What about OS? So there was a trend towards improvement in OS. Early data, I think so, but I think in future you might have it. See the hazard ratio 0.49, but because of small number of 70, it did not reach statistical significance. So what about toxicity or dose modification? Encorafenib seems to be a safe drug. 8.5 discontinuation, reduction in 1 in 5, and interruption in half. So half interruption, 1/5 reduction, and 1/10 dose stopping. So a good drug at all. So what did the author suggest? Statistically significant and clinically meaningful improvement in ORR, a trend towards overall survival improvement, and it supports that backbone may not be important. So if I have given a Folfox in the first line, should I reuse a Folfox when it metastasizes? So I think so. We have a data to say that Folfari works as good as it, again for those patients who already has neuropathy due to some causes. So my take is chemotherapy backbone may not influence outcome in BRAF mutant CRC. Incora plus Cetuxi plus chemo, standard of care in first line. You use Folfox or you use Folferi, better than a BEV containing combination. And the last part, because I think I have 2.5 minutes left. Can I prevent? I think this was the most debated topic that I have started presenting in my non-oncology forum. Can a drug prevent cancer? I repeat myself. You remember your Alaska study last year, it was aspirin in PIC3 stage 3 high risk post treatment for 3 years. This is not there. This is aspirin versus glucagon like peptide 1 receptor agonist. Can anybody know what is this Munjaro? A drug which we are using to reduce obesity. That is glucagon like peptide receptor 1, semi-glutide, what we say. They compared those with aspirin in the primary prevention. So if I am taking this semi-glutide, am I reducing my cancer incidence? So this was the biggest world head-on study, and probably this is what I wanted to present. That was the main aim. What preclinical studies suggest that GLP-1 receptor agonist has an anti-inflammatory and anti-neoplastic property, inhibits the PIC3, same point as PIC3 AKT mTOR pathway, like aspirin. But they wanted to say that aspirin, we have a data, but is it better than aspirin? So it will be a very difficult thing to do the prospective study. It was a retrospective head-to-head comparison between aspirin and GLP-1 receptor agonist. 1 lakh 50 patients versus 3 lakh, final was 1 lakh 40. So 1 lakh 40 is a big data which they have tried to compare in the population. Now see the improvement. A 36% reduction in the risk of CRC incidence when the people who are using semi-glutide or GLP-1 agonist, against the standard probably which people are using is ecospirin. And this quantum of benefit for irrespective of age, BMI, atherosclerosis, use of tobacco, diabetes, or which drug you use. So probably yes, any of the drug GLP-1. So probably in future you might have it, or probably those diabetic you are using, or those who are using it for obesity probably have a slightly protective effect in reducing the incidence of CRC. So the conclusion was, in a real world head-to-head, GLP-1 use was associated with a 36% reduction in CRC compared to ecosprin. The large population size of this study and the favorable safety profile of GLP-1 receptor agonist versus ecosprin could underscore a potential public health impact. Remember, the side effects which some might have is a abdominal pain and diarrhea. So probably you may have a prospective data, but I am excited that there is some prevention which is available. So here are my take home. This is a take home for the my fifth. Aspirin or GLP-1 agonists have rekindled our interest in preventive oncology in CRC. But again, people may argue with me that we don't have a phase 3 prospective study to prove my hypothesis. So if I have to summarize my take home message, 5 trials. If you have taken a photo because I don't give my slides. Horizon GA01 practice changing, yes. Capital suggests that platin plus 5-FU is a standard of care in post-op setting. You use S1, you use capecitabine, you use Folpop. Commit, which was the atezo with chemo, no clinical significance except reinforcing the role of IO. IO you have to give it off whatever way you. Breakwater cohort C. EC with chemotherapy backbone. Folferi or Folfog don't make a difference. It is far better in terms of your ORR, PFS is there, and in future we'll have a OS also. And last but not the least, a preventive oncology. GLP-1 agonist may become first drug which may reduce cancer incidence. However, we need have a phase 3 data, but I'm convinced. I don't think phase 3 data can come in a preventive oncology. Takes years and years and probably lot of biases and lot of things. And I thank you all. I again thank Deepak. I'll be happily answering the questions because this was what, if you go through it, there was some data of 4-year update of Nivo with in RCC. Sorry, I beg your pardon, hepatocellular carcinoma. There was some update about this Matterhorn study, but actually that was not clinically relevant here. And key surgery, how many of them? These are the 5 studies. If you can take, if you have listened to it, this was what this ESCO GI 2026 told us. So I thank you again for a patient hearing.
So, Dr.
Thank you,
Bharat,
Dr. Bharat.
excellent talk. Excellent talk by all standards as always. So, thank you so much for your time. So, Dr. Deepak Gupta, sir, comments from your side, sir.
No, thank you, Dr. Bharat, for sharing this interesting and practice-changing abstracts with us. And it was really very good presentation from you. And with this, I think this was our last session. So we will conclude the meeting. Fortunately, we are on time today also. So thank you, Tarunji, for providing all the support. And with this, I think we should conclude.
Yeah. So thank you so much, Dr. Deepak sir, for giving these opportunities. On your behalf, we thank all our academic partners for the support. Thank you to all the speakers today for doing a great job. And with this, on behalf of my colleagues Daud and Pooja, we say thank you, goodbye, till we meet again. Stay safe and stay black. Good night to all of us. Thank you. Good night, everyone. Thank you.
Good night.
Tag team, please close the meeting. Thank you so much.
Okay, sir. Thank you.